Good afternoon, everybody, and welcome to this Royal College of Radiologists Symposium. My name is Dr. Ben Timmis, and I'm joined today by Miss Alison MacKay, and we're going to be talking about improving patient safety in tele-radiology. So here we are. This is me on the left, Dr. Ben Timmis, and my colleague Alison MacKay is on your right. Alison.
Just a little forward, just to give you a little bit more background about who Fourways are. So we are a multi-accredited provider. We provide remote radiology reporting services across the NHS and to a number of private clients as well. We operate day and night, 24/7, 365 days a year, and we serve about 70 NHS trusts as it stands and around 160 sites. We're supported by a reporting panel of consultant radiologists. About 235 currently provide their services for us. They're all UK based. No data leaves our shores and all activity is conducted in the UK. All of our radiologists are GMC registered, hold the FRCR, and we all work in accordance with good medical practice and the codes of conduct and hold the required certifications to provide reporting services as if we were in the NHS itself.
So how do we go about this at Fourways? We look upon this as having building blocks to result in improved patient safety. And you can see those blocks across the screen. It's about engagement for technology, minimizing the distractions, supporting the radiologists, managing work volumes to keep services safe, monitoring the outputs, dealing effectively in consistency with discrepancies, monitoring the overall performance of the company, and then looking at the results of what we have done.
Our first hurdle, if you like, is radiology engagement. So we partner very much with the NHS. The majority of our radiologists, as I said previously, are consultant radiologists based in the NHS themselves. Before they join and start reporting for Fourways, we go through their CVs and they are reviewed by either Ben or a member of the clinical leadership team that support him. And we make sure that the appropriate skill base is there from their own day-to-day practice before they join Fourways. Dr. Timmis or one of his colleagues will also hold an interview with that radiologist. Certainly at the moment that's more remote over the phone or Teams, but when we're allowed to, those are also face-to-face where possible. We encourage our consultants to have a portfolio of interests, so we don't look that they will only report for Fourways exclusively, and we are encouraging that radiologists work either in the NHS or private healthcare or in locum practice to make sure that they're in touch with day-to-day best practice and changes which are happening a lot, particularly at the moment. As radiologists join our panel, we ask them to start slowly, they build up. We don't hit them with huge volumes. We want them to get used to our processes and our systems. And then once they've gone through that and they're comfortable, where relevant and depending on their own specialties, they'll join our more specialist panels if they wish to. We don't force any radiologists to do that. And if they volunteer and they meet the criteria for that panel, then certainly we'll accept them. We'll also look to volunteers to join our daytime and nighttime urgent reporting. Again, we don't force radiologists to do on-call, it's a voluntary basis. And again, they must meet criteria and go through an additional induction with our out-of-hours leads. So
obviously getting a technology right is a fundamental building block of our services. So all our radiologists use specific lockdown PCs and are provided with 2 high-resolution diagnostic monitors. It's important that PCs cannot be used for anything else to ensure security. We're running a latest operating system, which is Windows 10, IBM Merge PAX 8.0. All radiologists have 24-hour support via in-house dedicated IT teams. It's important that we don't expect our radiologists to be tech savvy. We provide all the support. All we want them to do is to report in a secure and safe environment. In the unlikely event of a hardware failure, we will arrange for replacements to be delivered the following day if required. Radiologists have the ability to access a second opinion online from a colleague also working. We provide them with free access to StatDX, and cybersecurity is paramount to our company. We have Cyber Essentials certified, regular ethical white hackers who test our system security, and it has never been breached.
As part of getting the technology right, along with the NHS and the rest of the world, we're also looking into what AI can bring to our services and to safer reporting. So we have a dedicated post within our clinical leadership team for AI and emergent technologies, and that's Dr. David Grant. We're in active discussions with a number of technology providers and vendors to look at what AI may be relevant and accepted for radiology and within the NHS, and where those decision support softwares can increase our safety even further. We won't hesitate to implement any form of AI or decision support within our workflows, assuming that the NHS is accepting of that, and where they will obviously enhance safety and efficiency as part of our reporting process.
So this is one of the key slides. We want our radiologists to work in a safe, distraction-free environment. So all our radiologists work from home. We have no set hours, we have no sessions, no reporting hubs, no minimum reporting obligations. i.e., we want our radiologists to report when they feel safe to report, when they're relaxed and ready, not when we tell them to. We give them written advice about avoiding distractions from partners, children and pets, etc. We have asked them to take regular breaks when reporting. We further encourage our radiologists to return cases if they feel tired or they don't want to report anymore, and we encourage them to return cases they have difficulties reporting, rather than just doing their best and moving on. We want the reports to be reported as accurately as we can, and we don't expect all our radiologists to have similar reporting skills.
In the spirit of that, and in supporting our radiologists, we don't run from an external call centre, but we have a single clinical and management hub, which is in our main offices at Hemel Hempstead, and that's staffed by humans, employed by 4Ways, and that's round the clock 24/7. Our radiologists have open access to our CEO, to Ben as the medical director, and other members of the clinical leadership team and the specialist leads, to any member of the senior management team and other specialists as required. We have a dedicated team that actually look after our radiologists and a dedicated relationship manager that focuses solely on the needs of our radiologists to make sure that they're comfortable in what they do on our systems and for our clients. We hold 3 CPD accredited quality assurance meetings a year, which obviously due to COVID have gone very much online and are via webinar this year. We ask that radiologists attend at least 2 out of the 3 of these, and that's a time where we can share interesting cases, any significant errors that are good from a learning point of view, and also we hold different presentations around different aspects of radiology to keep our radiologists informed and for their own education and continuing professional development.
Okay, we monitor the allocation of volumes for all radiologists, and if discrepancies arise, we assess any relationship that those discrepancies might have to volume, speed, timing, and we can adjust these parameters accordingly. I have to say that as far as we know, there is a poor relationship to any one of those parameters, and so it is difficult to ascribe a particular discrepancy to any specific issue, like numbers of images reported that session, speed or timing. But we do our best because we are trying to find ways to improve the safety of the output. The most important point is that no radiologist is pressured to report more than they want to and can safely undertake.
In that regard, we monitor all of our radiologist output via a structured audit. Our audit has been running for many years. We're in our 13th year now of formal auditing across our portfolio. As a standard, we audit 10% of all cross-sectional imaging and 2% of plain film. The audit is independent. It is by a distinct panel of radiologists and senior specialists, and away from those that are actually conducting the reporting themselves. It's an automatic and random selection that's anonymised, and it applies to all radiologists on our panel. Auditors are also audited. They are humans, they are radiologists themselves, and they too can make mistakes and apply categorizations differently. So between us, we make sure that there is a sense check that goes on across the audit panel as well as across the reporting panel. The other way, of course, that we come to know about any errors and discrepancies in reporting is from our clients' feedback. And given the combination of audit and client feedback, we hope to capture a majority of any significant errors. So in our systems, that would be category 1 or 2 errors as they arrive, and we can feedback and respond back to that very quickly to our clients, meaning that action on patients and any change in management that may give rise to can be actioned to hopefully improve those patient outcomes.
So this is a key issue, the audit process and managing a discrepancy. Each of the standard discrepancy categorizations is handled in a different way. We can explain that if required in a Q&A session. We treat discrepancies as learning opportunities, both for the individual radiologist concerned and for the whole reporting team if the learning opportunity is regarded as of wide significance. Radiologists who have discrepancies are supported, they're not criticised, and they're encouraged to discuss any issues with the medical director, i.e. me, should they wish to. And I converse with radiologists both by telephone and by email and try and support all of them to understand the pressures that they are experiencing. All radiology reporting output is monitored for discrepancies, and radiologists are supplied with an annual statement of their whole report performance to support their appraisal process.
As I said previously, the other way that we unfortunately get to hear about errors and discrepancy in reporting is when they are raised to us by our clients. We have a very formal process again for responding to client concerns and to any potential discrepancies identified in that way. Once we've reviewed that case in a similar way to the audit, where we apply a categorization by one of our auditors or specialists, then the radiologist is informed, the discrepancy categorization is shared, and if the reporting radiologist agrees with the discrepancy, then they will add an addendum to the patient record and the referring clinician is alerted that there's been a change. Where they disagree, and obviously opinion does come into radiology reporting and assessment an awful lot, then they have the opportunity to discuss that with the auditor themselves, and where required, we can then escalate that to the clinical leadership team and ultimately to Dr. Timmis as our medical director, who will have the final say and be able to opine with his experience on a final outcome and next steps.
So, audit underpins our regulatory duties, compliance with sector standards, QSI, and of course no such statutory audit requirements is currently running within the NHS. It maximises the learning potential for our radiologists and improves reporting precision. We ensure a random selection for each client and individual radiologist reporting out by modality and subspeciality, and obviously to improve impartiality. The name of a reporting radiologist is completely anonymised. When I see a case, I have no idea who the individual reporter is until I've already made my decision about classification of a discrepancy.
So this slide just gives an overview of the audit methodology that Fourways uses. So we inherited over the years what was the Department of Health's own endorsed categorisation scale. Is it right? Is it wrong? That's a different debate and a different speech. But ultimately, it's the one that we use and we've used for 13 years or more, and it's the ones that our clients broadly accept and understand. As I said previously, we audit 10% of cross-sectional report and 2% of all our plain film reporting, and that's conducted monthly. And that is also covers not only per client, but per radiologist, so that any audit reports that go to our clients are specific to the activity that is reported for them and specific to the radiologists that have reported that activity. The classifications that are listed on the right show the clinical relevant and significant discrepancies discovered in audit as 1 and 2, and these are dynamically alerted to make sure that patient management can continue in the appropriate way, regardless of what quality assurance and further review mechanisms we're implementing internally with the radiologist. As part of an audit or a case review, the auditor will give consideration to three main areas: clinical error, the actual clinical content of the report and what was clinically missed or misinterpreted; the language and the transcription. We all know that an error in a well-written, correctly constructed report comes across far less severe, as it were, than something that is poorly written, poor grammar, and is hard to understand to start with. And even correct reports that are written poorly but are of poor grammar and unclear to understand, not well received by anyone, and certainly by any referrers in the NHS that we've had the pleasure of working with. And the other thing we look at is the general report format. We aim to work to kind of a standard template whereby it's findings, conclusions, and where relevant recommendations. And we make sure that our radiologists are broadly following what is ultimately best practice in the NHS.
So this is a slide which I'm most proud of. It shows that we have sustained year-on-year improvement in our discrepancies, despite at the same time getting rising volumes of both demand and increasing numbers of radiologists engaged. Why we have these improvements is a multifactorial thing, difficult to understand, but it is a culmination of all that we've discussed in the previous slides. And so the results are really clear and speak for themselves. That said, we've got no room for complacency. We work to continuous improvement, and whilst we recognise that we can never get to 100% reporting accuracy with no discrepancies, we continue to pursue that elusive target.
So to summarise, where does this all actually come into improving patient safety and patient care in the NHS? Well, ultimately, around 88% of trust health boards outsource reporting to the independent sector, and that's from the RCR's own clinical workforce census from last year, 2019. Reporting that is provided by the outsource companies is always to a defined turnaround time, and this itself supports earlier diagnosis and therefore hopefully improved outcomes and a quicker patient management onto the correct pathway. We engage with consultant radiologists and we report exclusively from the UK, and the vast majority of our radiologists are consultants practicing in the NHS. With our cycle of audit and learning and continual improvement feedback, this goes back into the NHS itself and into their own NHS practice. So we complement the NHS best practice by trying to mirror some of the activities and the learning and make sure that that's not only about benefiting Fourways and benefiting specifically the patients that Fourways report upon, but the wider population that's served by the NHS itself.
So I'd like to thank you all for listening to this session. We're sorry we can't be here in person, but we all understand the reasons why. But that said, Alison and I will be happy to take any questions in our Q&A session, and we will do our very best to answer them. Thank you again for listening.